Hello everyone. So in this video we're going to talk about brain cancer. Before anything else, it is but important to have an idea as to what brain is. It is said that brain is part of the so-called central nervous system, other than the spinal cord that we know very well too, is somewhat related with regard to the overall bodily functions. So in line with brain cancer, you need to understand somehow the etiologies, the risk factors associated, and basically there are a lot of conditions that can be associated with brain cancer. So in this video, you will be able to somehow familiarize yourself with the different types of brain cancer and as to what specific manifestation will we be expecting for a particular type. So in this case, let's have some sort of an understanding as to what brain cancer is. Brain cancer is considered to be a particular growth that occurs inside the cranial cavity in the form of tumor growth inside a particular brain tissue, or it may somehow be related to a tumor that has grown in the meninges. And we know very well that meninges simply would refer to the covering or the one that provides protective layer on the sensitive or very delicate brain tissue. So if there will be tumor growth in the brain tissue, that is still part of brain cancer. Similarly, if tumor has grown inside these meninges, it will still be part of the so-called brain tumor. Now, if it also has somehow grown a particular tumor in the pituitary gland, that will still be part of our classification with regard to brain tumor and associated blood vessels. So basically, when we talk of brain cancer, we do not only refer to the tumor growth inside the brain tissue, it also would like to refer to the tumor growth in the meninges, in the blood vessels, and also in other parts of the cranial cavity. Now, another thing that you have to remember is that when we talk of brain cancer, we have the most common type, and that is in the form of glioblastoma multiforme, which is followed by meningioma among adults. Now, we proceed with the next slide. With regard to the risk factors of brain cancer, this is basically unknown. However, in terms of gender, it is said that men commonly experience this glioma, while women commonly experience meningioma. Now, we will be able to appreciate what are these terms later on. If the client has a history of viral infections such as EBV or Epstein-Barr virus, the client may also be at risk to develop brain cancer. Similarly, if the client had experience of head injury causing somehow jarring of the head or maybe causing inflammatory responses or processes involved with the brain tissue, the client is also likely to develop cancer. You have to remember that with regard to type or pathogenicity of cancer, it will always start with tissue injury, and basically the response of the body towards injury would always be inflammatory process. And so if there will be tissue repair on that particular area, that is where mutation or cancer process would set in. Now, the other risk factors associated with brain cancer may include immunosuppression, and we know very well that in an immunocompromised state, the checkpoints may not be able to work properly, and so the defective cell is allowed to progress from one phase to the other. And the phases would include, again, G1, followed by S phase, followed by G2, and finally the M phase. And in every phase of the cell cycle, basically the cell is being observed in terms of any abnormality in structure. And if there is an abnormality in the structure, that cell is not allowed to progress in the next phase. Now, it is actually the immune system that will watch it. And so if the immune system is not competent enough to watch out for any defective cell, somehow this defective cell will be allowed to duplicate, and as the process continues, basically that is where cancer sets in. Now, another will be in the form of cranial irradiation or radiation therapy, because radiation is able to pass through the cell even in the presence of an intact skin. So radiation, as it is able to transfer or as it able to pass through a particular cellular structure, can actually lead to a DNA defect. And we know very well that DNA is somewhat the genetic makeup of a particular cell, and it will tell as to when the cell will divide and as to when cell will have to die at the right time, called apoptosis. Now, genetics also plays a role with regard to the pathogenicity of brain cancer. Now, let's talk about the classifications of brain cancers. We won't be talking into particular detail every type of cancer here. We will just be giving you examples, or I'll just be telling you examples of brain tumors, and from there we can actually be somewhat familiar with these specific types. Take for example, we have a first general classification, and that would be in the form of intracerebral tumors, basically the tumors that have grown inside the brain tissues. And intracerebral tumors are often referred to as glioma. And it has three subtypes that would include astrocytoma. So basically, these three subtypes will be based from the typical type or the specific type of cell being involved. Take for example, we have these so-called astrocytes in the CNS, and if these astrocytes tend to have malformation and cancer has progressed in this type of cell, basically it is termed as astrocytoma. We also have another term in the form of ependymoma, which actually arises from ependymal cells of the CNS. Oligodendroglioma, which is actually a form of tumor that involves the oligodendrocytes. Now, you have to remember that when you talk of astrocytoma, it is of two specific subtypes. If this is already considered to be a subtype, it is further divided into specific subtypes, such as glioblastoma multiforme, which is considered to be the most malignant form, and it is fast growing. And another one, and that is in the form of astroblastoma, which is considered to be benign. You have to remember that in between neoplasm that is considered to be benign or malignant neoplasm is considered to be the most severe or the more severe form of neoplasm, simply because it is a fast-growing tumor. Now, when we talk of brain tumor, somehow, when we talk of benign tumor, we cannot readily say that it is considered to be non-safe or it's considered to be not severe, because basically there should not be any tumor present in the cranial cavity. So, whether it is slowly growing or fast-growing, the mere sight or the mere presence of a particular tumor somehow can increase the intracranial pressure. And we will be talking about intracranial pressure later on in our management. Now, of course, if we are going to compare between malignant or benign neoplasm in the brain, of course, malignant type is considered to be more dangerous. However, be it benign, it is still dangerous to know as compared if it has formed in other parts of the body. Now, another second classification will be in the form of extracerebral tumors. Now, it has specific subtypes. The first one will be in the form of medulloblastoma, which is a fast-growing tumor, and it involves malignancy occurring in the cerebellum. And we know very well that cerebellum is in line with the balance of a particular individual. So imagine if the client is diagnosed as having medulloblastoma. Imagine that this client would most likely have imbalances or unsteady gait and problems with coordination. We have the next one, and that is termed as meningioma. So with meningioma, you have to remember that it is a slow type of tumor. It forms in the meninges, and that it is firm and encapsulated. The third one will be called as acoustic neuroma. Acoustic neuroma basically affects the cranial nerve, and the cranial nerve number 8, which is actually the vestibulocochlear nerve, which is responsible for the balance at the same time hearing. So if the client has acoustic neuroma, you would expect that the client may have hearing loss or hearing problem, and also a problem with the balance. Now, this acoustic neuroma is able to infiltrate other cranial nerves or affect other cranial nerves that would include cranial nerve 5, 7, 9, and 10. And you know very well that 5 is trigeminal nerve, 7 is facial nerve, 9 and 10 will be glossopharyngeal and vagus nerve respectively. We proceed with the third major classification of brain tumor, and that will be for the congenital malformations. With developmental tumors, it has two subtypes. The first one is hemangioblastoma, affecting the blood vessels. That is why it is considered to be a vascular tumor, which is a slowly growing type of tumor. We have the second one, and that is craniopharyngioma. With craniopharyngioma, you have to remember that it is a cystic tumor that basically compresses the pituitary gland and could actually obstruct your CSF flow. Now, with regard to the next one, this is the fourth major classification of brain tumor, and that would be pituitary adenoma. From the word pituitary, more or less this tumor is formed near the pituitary gland. Well, anyway, let us take a look. We have three specific subtypes for pituitary adenoma. The first one is chromophobia, which accounts for 90% of all the cases in pituitary tumors, which is non-secreting tumor and slowly growing. The next one is eosinophilic. With the eosinophilic type of tumor, it is a secreting tumor, that produce growth hormone. You know very well that growth is responsible for an increase in the length of the bones in line with increase in the size of the organs and of the muscles. So imagine if the client has somehow an eosinophilic tumor, and you know very well that somehow there will be an enlargement of the body organs, there might be an increase in size or height of a particular individual. The next one is basophilic pituitary adenoma, which is a secreting tumor that this time around produces adrenocorticotropic hormone. Adrenocorticotropic hormone is somewhat produced by the pituitary gland. The pituitary gland produces the adrenocorticotropic hormone that stimulates the adrenal gland to release the three S: sex, androgen, salt, mineralocorticoid called aldosterone, and finally the last S, sugar, which actually secretes the glucocorticoid. So imagine if the client has basophilic pituitary adenoma, you somehow expect that the client has hyperpituitarism, meaning hypersecretion of this hormone by the pituitary gland, actually specific to adrenocorticotropic hormone. So there will be somehow now elevation of aldosterone, of glucocorticoid, and finally androgen, causing a disease called maybe Cushing syndrome, right? So we proceed with the next one, and that will be the clinical manifestations. The manifestations are always related with the specific type or specific location of the tumor. Take for instance, if it is growing inside the frontal lobe, somehow there will be a problem. Now, frontal lobe is actually related with personality, related also to voluntary activities, to motivation. So somehow this can be or this tumor that has grown inside the frontal lobe can basically affect concentration, motivation. So basically the manifestations would include inappropriateness of behavior, personality changes, inability to concentrate, an impairment in the judgment, headache, expressive aphasia, motor dysfunction. Let's talk about expressive aphasia. It is said that in terms of expressive speech, the way that we talk, the words that we articulate and how we are to voice them out, or the words that we produce in order to form speech, is actually a function of what we call as the Broca's area. And Broca's area basically is found in the frontal lobe. So if there is now this frontal lobe involvement, the client may also have a problem with expression of speech by way of words. And so the client may able to understand the speech that you're actually talking, that you're actually telling the individual. However, that client is unable to express his or her speech through words. So basically the client may have now this what you call as expressive aphasia. Now we proceed with the next one, and that is parietal tumor. If it has involved the parietal tumor, the client may have a problem with sensation, because when you talk of sensation, this is more of the function of the parietal lobe. So the client may have sensory deficits such as paresthesia, loss of two-point discrimination, and visual field defects. Well, you know very well that when you talk of the visual function, it's more of the occipital lobe. We proceed with the next one, and that is temporal lobe tumor. With temporal lobe tumor, the client may have psychomotor seizures. Knowing that temporal lobe is also responsible for hearing at the same time memory, the client may also have problems with memory at the same time hearing. The next one would be occipital lobe tumor, and that is mainly related to visual function. So if the client has tumor in the occipital lobe, the client may report visual disturbances or complaints. The next one will be cerebral tumor, and so the client basically will have a problem with gait or posture. So the client may have disturbance in coordination and equilibrium. Lastly, we have this pituitary tumor. If the tumor has grown inside the pituitary gland, it will now hypersecrete hormones, such as it will be dependent as to whether it is anterior or posterior pituitary gland. So if it is posterior, of course, we know very well that there are two hormones there. We have oxytocin and this antidiuretic hormone. If it is in the anterior pituitary gland, of course, we have several hormones that will be including FSH, LH, growth hormone, and many more, or TSH, and many more. So with regard to this pituitary tumor, of course, there will be now problem with the endocrine system, and we know very well the hormones responsible for the endocrine system. The client may also have visual deficits and headache. If you're going to look at it, if the tumor is actually present in the cranial cavity, the client will automatically complain of headache, owing to an increase in the intracranial pressure. Now we proceed now with the next set of manifestations if in case the client has brain tumor. This will be in line with an increase in intracranial pressure. Normally, intracranial pressure should be less than 20 millimeters mercury, and if it is consistently above that, that is already suggestive of intracranial pressure. Although there may be invasive procedures in order to measure ICP, it is but important for us clinicians or for us members of the healthcare team to be familiar as to what will be the specific manifestations of the client with increased ICP. Now, you have to remember the concept related to ICP or intracranial pressure. You have to remember that there are basically three components that influence the pressure inside the cranium, and that would be the brain tissue itself, the blood vessels, and finally the CSF. Now, in the event that there is an increase in the CSF production or impaired excretion or impaired flow of CSF or increase in the diameter of the blood vessels or an increase in the tumor or increase in the mass, of the brain tissue, such as in the growth of a particular tumor in the brain tissue, the cranium will not expand or will not increase in its capacity just to accommodate this growth, this excessive CSF, or this increase in the diameter of the blood vessels. So basically what you have to understand is that it is different with that of the abdominal cavity. Like if you engage yourself in excessive food intake, somehow this can affect an increase in food intake can somehow expand the stomach without a problem somehow, because somehow the body will have to extend or expand just to accommodate an increase in the volume. However, in intracranial pressure or in the concept related to ICP, the cranial cavity will not expand just in case there is an increase in the mass of the brain tissue or an increase in the blood flow or an increase in the diameter of the blood vessels or an increase in related to CSF production or an impaired CSF flow. So that is the main concept behind that. The cranium will not accommodate, will not somehow extend, or will not somehow adjust to an increase in the volume, and so that is where the concept of ICP is. The client will manifest signs and symptoms of increased ICP because the brain will not do something to correct the problem. In fact, the brain tissue will have to herniate in the event that the ICP is so high that the body can no longer adapt to this increased ICP. So what do you think now will happen? The brain tissue will just have to herniate, specifically the medulla oblongata. The medulla oblongata will have to herniate just to accommodate an increased pressure inside the head. And you know very well that if there is brain herniation, that is almost always automatic to death of a particular individual. So that would be our intervention. Prevent activities that can increase the ICP, promote activities that can reduce ICP, or prevent the factors that could somehow aggravate the presence of an increase in ICP. So let's talk about the manifestations. Increase in the brain volume will cause or in the presence of displacement or maybe edema. Increase in CSF volume may be related to obstruction of CSF flow, or maybe increase in the blood volume brought about by an increase in vascularity of the tumor. You know very well that the tumor can actually stimulate angiogenesis by promoting release of VEGF that stimulates blood vessel production in such a way that somehow the tumor cells need nourishment, need oxygen, need nutrients or glucose to somehow make these cells survive. Another will be in line with decreased perfusion or nerve necrosis, simply because of an increase in ICP. There will be now a problem with perfusion or oxygenation of the brain cells. The client may also experience headache, which is often worse in the early morning, which can be localized or may be global, affecting the entire head. It may be worsened by the so-called Valsalva maneuver. What does it mean by Valsalva maneuver? You are exerting increase in pressure in the abdomen in the presence of a closed glottis, meaning somehow you are increasing the pressure inside the abdomen that the pressure basically can come to your head. So but that is Valsalva maneuver, and basically headache can be further aggravated if the individual practices or performs specific activities that can increase the Valsalva maneuver, such as straining during bowel movement, such as excessive coughing, such as vomiting. These are somehow some of the activities that can increase intracranial pressure. Headache may be described as dull, sharp, or throbbing, or progressive. We proceed with the next slide, and that would be the late signs of increased ICP. You have to remember that these are the late signs. Early signs would somehow include an altered level of consciousness, but with late signs, we have the so-called Cushing's triad. Well, anyway, I think we'll be talking about this sign, Cushing's triad, and basically there are three manifestations in increased ICP, Cushing's triad. That would include hypertension. You have to remember that in hypertension, there is elevated systolic pressure, meaning 120 over 80, systolic pressure is the 120, and it is usually the systolic pressure that is of the higher side. The question is, why do we have elevated systolic pressure? Because it is believed that in increase in ICP, there is a decreased oxygenation of the brain cells. So the heart somehow compensates with a decreased oxygenation of the brain cells by increasing its pressure in order to pump enough blood going towards the brain. That is why it can be easily evidenced by increased systolic pressure. Usually the diastolic pressure remains normal. That is why increasing systolic while the diastolic remains normal, such as from 120 over 80 it becomes now 150 over 80, finally it becomes 160 over 80. The pulse pressure, meaning the difference between systolic and diastolic pressure, from there is 160 minus 80. That means it is 80 millimeters mercury. And you know what? The pulse pressure should be only between 30 and 40 millimeters mercury. Such a way that 120 over 80 is a normal BP reading, and so this so-called pulse pressure is 120 minus 80, it is 40, and 40 is still within normal range. Now, if you have a blood pressure reading of 160 over 80, that may mean that the pulse pressure is 80 millimeters mercury, which is above the normal range of 30 to 40 millimeters mercury. And that is what we call as widened pulse pressure. Widened pulse pressure, meaning there is a wide gap between the systolic and that of the diastolic. Now, other than hypertension, the client may also have bradycardia owing to stimulation of the vagus nerve. We know very well that the vagus nerve, vagus is parasympathetic in dominance, causing now bradycardia. The client may also have irregular respirations in the form of the so-called Cheyne-Stokes respiration. What does it mean by Cheyne-Stokes respiration? The client has a progressive increase in the rate and the depth of respiration, meaning it is rapid, at the same time very deep breathing, that gradually decreases in rate and depth, and finally the client will have apnea. Apnea meaning cessation of breathing. And then the cycle continues, meaning the client will have again rapid and deep breathing followed by a gradual decrease of respiration, and then finally going again to apnea. That is what Cheyne-Stokes breathing is. And in the presence of Cushing's triad, basically this indicates a poor prognostic sign, meaning the client is basically having some sort of a deteriorating neurologic function. The client may also have papilledema. Papilledema simply refers to compression of the optic nerve brought about by increase in ICP. And basically the client may have blurring disturbances. The client may also develop seizures brought about by an impaired neuronal activity or excitability. The client may also have pupillary changes. So in this case, the client may have unequal pupil size, evidenced by this so-called term as anisocoria. Another will be GSS scoring, and that if it is less than 8, that is already suggestive of coma. Another will be abnormal posturing, depending if it is decorticate or decerebrate, meaning abnormal flexion is decorticate, abnormal flexion will be decerebrate. The client may also have hyperthermia or temperature elevations in line with increased ICP brought about by a problem with regard to the hypothalamus, which is a thermoregulating center. We proceed with neurologic manifestations. Although we've been mentioning neurologic manifestations, what are these specific neurologic manifestations? The client may have visual problem, motor problems such as body weakness, changes in level of consciousness, which is actually the most sensitive indicator of neurologic change. That would include lethargy, apathy, confusion, restlessness. And the client may have alteration with speech, such as Broca's aphasia or Wernicke's aphasia. What is Broca's aphasia? The client may not be able to articulate his or her speech through words, but the patient is able to understand what you are actually saying him or her. We have the next one, and that is Wernicke's aphasia, meaning the client is able to talk to you in words. However, whatever that you talk to him or her is not understood by the client. So the client has a problem with speech comprehension. That is Wernicke's aphasia. The client has a problem with speech production. That is Broca's aphasia. Now, the client is not able to understand you. The client is also unable to talk to you through words. That is global aphasia, meaning both Wernicke's and Broca's in combination. Now, the next one will be in line with gastrointestinal manifestation that are not that really specific but includes anorexia, nausea, vomiting brought about by compression or involvement of the medulla oblongata that is unrelated to food intake. We proceed with the diagnostic tests, and that would be inclusive of CT, MRI, PET scan, and bone scan. Why bone scan? Because the bones may actually be involved in relation to metastasis. CT or MRI or PET scan to outline somehow the structure of the tumor, whether it's so big that it can significantly increase the ICP and cause neurologic symptoms. Electromyography is in line with development of muscle weakness to somehow determine as to what cause of muscle weakness are we talking about. Is it related to innervation, or is it related basically on the lobes specific or affected by the said tumor? Lumbar puncture is somewhat indicated in order to determine if there is any cancer cell present. So basically, there will be aspiration of CSF to determine the presence of cancer cells if there are any, or maybe to determine any underlying microorganisms that can somehow cause the presence of encephalitis, meningitis, take for instance, just to rule out any neurologic disorders. So basically, with a lumbar puncture, you have to understand that the client is placed on a fetal positioning or shrimp-like position, and that there will be an insertion between L3 or L4 or L2 or L3. It will depend on literature. But basically, there will be insertion of the spinal needle in order to aspirate the CSF. Although you have to remember that the absolute contraindication of lumbar puncture will always be increase in ICP. So this is very important, because if the client has increase in ICP and lumbar puncture will be performed on this client, there is a tendency that upon aspiration of the CSF, the client may suddenly experience brain herniation and the client will die. So that is one thing that we, as members of the healthcare team, be cautious about. Well, of course, the neurosurgeon is very familiar with that. It's just that increase in ICP is considered to be an absolute contraindication for performance of lumbar puncture. Now, immediately after lumbar puncture performance, the client is usually placed on flat on bed, meaning supine positioning, and there will be somehow a sandbag that is placed in order to somehow promote application of pressure, or sometimes there is no need for a sandbag, but basically the client is usually monitored, and that the client should be flat on bed just to prevent spinal headache. What is meant by sudden spinal headache? If the client will assume an upright position immediately after CSF aspiration, there is a tendency that the CSF will flow into downward direction, and so the brain basically will be losing CSF. And so that is where spinal headache sets in, meaning CSF is very important in such a way that it provides cushion to the brain's tissues in the bony ridges within the cranial cavity. So absence of CSF could somehow cause irritation at the same time as bumping of the brain tissues in these bony prominences of the cranial cavity, causing spinal headache. Now, ICP monitoring in order to somehow determine the extent of increase in ICP, whether it's so dangerous that the client may actually lead to brain herniation. And you know very well that of all the structures of the brain that will initially herniate, it's going to be the brainstem, specifically the medulla oblongata, causing now death, because medulla oblongata is responsible for respiration, breathing, with regard to vasomotor tone, and that. Okay, so there is actually a slide here, and we are going to talk about now the management, which is actually the last part of our discussion here. And you can see in here that there is an instrument with the cutter at the end, and that it has been introduced between the gingiva and that of the upper lip. And that is usually the usual approach. Or we can say that it could be intranasally, which is another form of approach of entry of that instrument. And that it is going upwards to reach the sphenoid bone, a depression in the sphenoid bone called sella turcica. And basically, they would like to gain access to the so-called pituitary gland. Now, if the tumor has grown in the pituitary gland, such as pituitary adenoma, they would like to remove that in order to relieve the client from these endocrine disorders. And that is what we call as transsphenoidal hypophysectomy. So basically, considerations will be in line with oral care, gingival care, and somehow, since it has involved resection of a particular tissue of the brain, somehow we need to watch out for possible complications such as diabetes insipidus, which will later on be discussed. So let us proceed now with the management. Surgery. Now, surgery may involve craniotomy, creation of burr holes. It will depend on the neurosurgeon's preference, but basically, if there will be surgery that will be performed, a sample tissue may be obtained, and that will be in the form of stereotactic brain biopsy in order to determine if the tumor cells are considered to be malignant or benign. We have the so-called brain surgical resection, a certain removal of proportion of the tumor that may serve to provide diagnostic testing, or in the form of improvement of clinical outcomes in order to somehow reduce the ICP. Another surgical procedure, it will be in the form of transsphenoidal hypophysectomy, and the post-operative considerations will be inclusive of the following, such as protection of the oral site or of the gingival site, because that is where the incision is created. Frequent oral hygiene in order to prevent oral infection, because somehow the tissues have been irritated or have been injured, brought about by the incision, and so oral care will be indicated because that site somehow increases the risk for infection. Nasal drip pad assessment, because why? Because of a creation between a communication of the brain tissues, CSF, and that of the oral cavity. So in this, or of the nasal cavity. So in this case, we have to determine nasal drip pad assessment. We'll be talking about CSF leak later on. You have to remember that in any surgical procedure that involves the brain, the client is always at risk to develop the so-called diabetes insipidus. Diabetes insipidus is characterized by a decrease in the level of ADH. What is the function of ADH? It reabsorbs water. If there is a decrease in ADH, there is a decrease in reabsorption of water. So basically, urine will have an increased amount of water being excreted. So the client basically will have polyuria. The client will also have weight loss. The client is at risk to develop dehydration. And basically, the client will be at risk to develop hypovolemic shock because water is an important component of the blood volume. So you have to watch out now for the signs of polyuria or of diluted urine, because basically of an increase in the water content in the urine, the water becomes or tends to become very diluted, so it's very pale in color, and that the specific gravity is on the lower side, less than 1.010. Now, the management basically will be to hydrate the client, because the client is losing an increased amount of water in order to prevent dehydration. And so, since DI or diabetes insipidus is characterized by a low ADH, it is but important that we can give the client vasopressin or ADH medication in the form of desmopressin or vasopressin that can be given orally or by way of inhalation if diabetes insipidus persists. Usually, diabetes insipidus is usually temporarily, immediately after brain surgery. And so, if the client complains of increasing urination or increased thirst, you should suspect that most likely the client is on diabetes insipidus. So, check urine specific gravity. Check the amount of urine. And then, somehow we can rule out the possibility or determine the presence of DI. Next will be in line with radiation, because the tumor, if, take for example, becomes inoperable, meaning it cannot be evacuated safely, radiation therapy may be indicated. Now, chemotherapy will be the next one in the form of these medications presented in your screen. Alkylating agent in the form of temozolomide, or the second line of treatment. That is actually the first line of treatment. The second line of treatment will be bevacizumab, which is the second line of treatment, and other medications presented in your slide. Symptomatic management depending on the manifestations that the client actually presents, which would include the following. If it is in line with CSF obstruction of flow, the client may have the so-called ventriculoperitoneal shunting. Basically, the ventricles are the ones responsible in CSF production. Now, if there is an impairment in CSF flow brought about by the tumor that has formed, the problem now is that we need to do something about it. And so a shunt will be created will be inserted into the ventricles as to where CSF is usually placed, after which the shunt will be connected and will be further placed into the peritoneal cavity. Now, the peritoneal cavity is somehow the reservoir of the CSF, meaning CSF will be flowing from the ventricles going towards the peritoneum, where the CSF will be reabsorbed by the body. So that is what we call as ventriculoperitoneal shunting. Of course, you won't be seeing this tube outside of the body. It will have to be sutured under the skin. Now, another will be creation of an opening in order to somehow promote CSF flow in the form of ventriculostomy. Glucocorticoids are given because they are anti-inflammatory, decreasing cerebral edema. And another medication, chemotherapeutic agent, in order to somehow manage cerebral edema in the form of bevacizumab. Keppra is usually indicated for the first line of treatment for seizures. Phenytoin is actually an other anti-seizure medication or anticonvulsants, carbamazepine, and other medications presented in your screen. Let's talk about ICP management, which I believe is the last part of our discussion, or I think a second to the last. Now, management of increased ICP, and I did mention already about the concept behind it. Now, with regard to surgery, the bulking of the tumor, meaning reducing the size in as much as we can, the bulking of the tumor, removal of the clot if there is any, or shunt placement, or this what we call as Ommaya reservoir placement, which is actually created or sutured under the scalp, and from there it is safe to actually aspirate CSF in order to reduce intracranial pressure or to reduce the CSF that has an impaired inflow, which later on you can appreciate with the illustration that I will be flushing after this slide. The next one is hyperventilation. This is somewhat very important if the client has increased ICP. The client will have to be encouraged to increase in the rate and depth of respiration in order to promote respiratory alkalosis. Or sometimes, if the client has a mechanical ventilator in place, we will just have to increase this BUR or backup rate, or the rate of the machine that the client needs to inhale and exhale over a minute. So increasing the RR through hyperventilation would actually cause respiratory alkalosis. And respiratory alkalosis can actually promote cerebral vasoconstriction, meaning the blood vessels will become smaller, therefore reducing the ICP. That would be it. So our PaCO2 normal level is between 35 and 45 millimeters mercury. So in hyperventilation, our goal is to have a PaCO2 level between 36 to 30. So that would be it. So blood vessel constriction will actually promote a decrease in ICP. So chemotherapy, corticosteroids can also be given in order to reduce ICP because corticosteroids are believed to be anti-inflammatory, decreasing the swelling. Another management will be in line with administration of intravenous fluid. You know very well that hypertonic solution can cause shrinking of the cell. Therefore, if the cells have shrunk, there will be now a decrease in the mass volume. A decrease in mass or the volume inside the cranium. And that would be for hypertonic salines such as 3% sodium chloride or 5% sodium chloride. You have to remember that this fluid is given in very limited dosage because of the danger of cerebral dehydration and the danger of hypervolemia and resultant pulmonary congestion, because the fluid will be moving from the cell into the interstitial and finally in the intravascular space. Another will be anticonvulsants because increased ICP can actually lead to seizure development. Antipyretics because increase in fever can somehow increase the metabolic demand, requiring the need for oxygen of these brain cells, and we don't want that to happen. And sedatives in order to somehow prevent neuronal excitability. Now this is the Ommaya reservoir, and it has actually a tube that is connected directly in the ventricles of the brain where CSF is produced. After which it is connected to a collecting pouch, and this pouch is actually sutured under the skull, and basically we can actually aspirate from that area with the use of a needle and syringe, and we can collect sample for CSF to run for analysis, or we can directly administer chemotherapeutic medications if in case that we need to have chemotherapy or radiation for that. Watch out for signs of increased ICP that would include restlessness, agitation, decreased LOC, Other manifestations are actually presented in your screen that would include headache, vomiting, seizures, decreased sensory and motor function, and abnormal posturing. If you are to be asked with regard to abnormal posturing, whether it is abnormal flexion such as decorticate or abnormal flexion such as decerebrate posturing is more severe than decorticate, but basically they are both severe in nature or characteristic. A change in pupil size or unequal pupil size is actually termed as anisocoria. So basically it is important that if a client has a neurologic problem such as brain tumor, have a pen light with you at bedside to somehow evaluate and measure regularly or every 2 hours or 3 hours or 4 hourly depending on institution policy with regard to pupil size, whether it's 4 millimeters, 3 millimeters, or and both eyes or what. So changes in vital signs that may be including an alteration in the respiration, increasing pulse pressure, which is actually a late sign, part of the Cushing's triad, hypertension. Decreasing pulse rate, bradycardia brought about by vagal nerve stimulation. Increasing blood pressure, specifically the systolic pressure becomes elevated. We need to instruct the client to avoid activities that can increase ICP, and this must be somehow prevented. And we can also promote activities that can somehow reduce ICP. Avoid neck flexion, because neck flexion somehow impairs venous blood being drained from the head going towards the heart to the so-called venous return. So neck flexion should be avoided or head turning to the side. Prone positioning is also avoided because it can actually increase ICP. Increasing intra-abdominal pressure in the form of Valsalva maneuver. Therefore, if the client has a risk for increased ICP, the client will automatically be receiving a stool softener in order to prevent the client from experiencing constipation. Vomiting, therefore antiemetics may be given, so this could somehow be avoided. Coughing, sneezing, straining of bowel movement. All of these things written in this slide should be avoided, so therefore you need to be knowledgeable about these things. Suctioning for more than 10 seconds at one time, because this can actually stimulate cough reflex. Another thing would be clustering of activities. We don't want the client performing all of these activities or the nurse performing all of these activities at the same time, because this can somehow increase in the pressure, intra-abdominal pressure, increase in ICP will be the resultant effect, such as suctioning, turning, and bathing all at the same time will have to be performed in a 30-minute period. Take for example. Let's talk about the activities this time that prevent ICP or activities that we will be doing in order to somehow reduce ICP. Elevate the head in order to manage cerebral edema at least 15 and 30 degrees. 15 to 30 degrees. The next one will be keeping the head in midline position or in neutral position, unless if the client has a bone flap on this side, such as on the left side. Well, in my screen it's on the right side. But basically, what you have to remember, if the client has a bone flap in this area, the client should not be turning towards the operative side, because this can actually increase in pressure in the area. So the client's head should be positioned on the other side, an operated side, in order to prevent complication. Log rolling technique can somehow prevent the client from having this Valsalva maneuver, plus the fact that it can actually reduce the ICP. So in line with that, log rolling technique is an efficient way of transferring a particular individual in such a way that the client will be transferred as a single unit. Because turning the client from one side to the other not only increases discomfort, but it can also cause somehow complications related to increase in ICP, related to Valsalva maneuver, or related to cerebral edema. Now, avoid rectal route for temperature checking, because once the thermometer will be inserted into the rectum or into the anus, there might be a possibility of stimulation of the vagus nerve, causing bradycardia, and you know very well that increased ICP causes bradycardia, and we would like to prevent that from happening. The next one will be the activities still about ICP, antiemetics for vomiting, stool softeners for constipation, analgesic for headache. Maintain fluid restriction because the client is already in cerebral edema and we don't want further edema. Internal shunting, whether it is internal or external, you have to remember that the shunt should be free from any obstruction, and we don't usually pump if there is any pump present unless directed by the neurosurgeon. Another will be promoting a quiet and restful environment, because if the environment is somewhat noisy, at the same time stimulating to the client will not be able to relax, and this can actually increase the ICP. Encourage calm interactions between patient and others. Finally, with regard to CSF leakage or infection, it is important to monitor for signs of CSF leakage. This can actually be applicable post-craniotomy, post-transsphenoidal hypophysectomy, or maybe post manipulation of the cranial vault. So in line with that, it is but important that if the client is suffering from nasal drip, take for example, we don't necessarily think it as a form of simple colds. Rather, we have to check the output for possibility that it is indeed CSF. Check for glucose, because CSF contains glucose wherein nasal secretions do not. That is an important thing that you have to remember. Check for the presence of glucose in the CSF that has been noted in the nasal drainage. Or drainage can actually be evacuated from the ears, and so we would like to prevent obstruction in the area. Let the CSF flow until the neurosurgeon comes to see the patient. Complaints may actually include like something dripping down at the back of the throat of the individual, or halo vision, meaning the CSF will actually be collected in a sterile gauze, and then you can actually see concentric rings that can be seen actually in the sterile gauze, known as halo sign or double ring sign, suggestive of CSF, and test the presence of glucose in the CSF. Prevent contamination of the area where the CSF is actually leaking. So in line with that, if it is leaking from the nose, keep the head elevated 20 degrees. Avoid nasal suctioning or trauma in that area, because this can actually favor further CSF leakage. Cleaning or putting something into the finger or placing a pack in that area is not helpful, because this can actually increase in pressure. Similarly, if the client has right ear CSF leak, the client's head should be turned towards the area, because turning the client on the opposite side could actually increase in the area pressure on that side. So let the CSF flow and just reinforce dressing, but no need to place this packing, because this can actually cause pressure in the area. Similarly, avoid putting your finger or placing a pack into the ear. Place instead a sterile dressing over the area of drainage and change as soon as it becomes damp, and let the neurosurgeon evaluate the client. Lastly, will be in line with monitoring of complications related to infection. Temperature monitoring, redness or swelling or bulging of the site of incision creation, or pain on the scalp, or increasing WBC or leukocytosis. The client may be at risk to develop meningitis, especially if the cranial cavity has been open. So watch out for signs of meningitis, inclusive of fever and chills. We know that very well. Increasing headache, neck stiffness, and we have this so-called Kernig's sign. Kernig's letter K, you have to remember letter K also, knee. If the knee will have to be flexion and extension of the knee can actually cause pain. And that is positive Kernig's sign, because usually once the client is placed on a supine position and then you're going to flex or extend the client's knee, there won't be pain basically, but if there is pain, that is suggestive of meningeal irritation, that is meningitis. Now let's talk about Brudzinski's sign. Brudzinski's sign tends to become positive once you are to promote flexion of the neck, and this can actually cause involuntary flexion of the knee and the hips. Again, flexion of the neck causes involuntary flexion of the knees and the hips, and that is positive for Brudzinski's sign. And photosensitivity. Measures related to prevent infection will be in line with strict aseptic technique, strict hand hygiene. The client's hands should be away from the incision site or any shunt that the client has if it is external, or any incision that has been created in line with tumor evacuation. And antibiotic therapy, and the sample may be sent for culture and sensitivity if the client has meningitis. The last part of our discussion will be in line with seizure precaution. The side rails should be padded, meaning in the case that the client has seizures, because of the movements tend to become involuntary, we don't want the client having unnecessary injury. Place the bed in lowest position, because if in case the client will go into seizure and the bed is placed in the lowest position, the injury may not be so severe as compared if the bed is on the higher side. Similarly, if the client plans to move out from bed going towards the bathroom, placing the bed in its lowest position can somehow be helpful and is very related with regard to safety precautions, because the client may not trip on the floor. Another will be carrying out interventions to prevent and treat increased ICP, because ICP increase is directly related with seizure development. An oral airway will be at the bedside just in case the client will salivate during seizure, and suction equipment available for use. And administer prescribed anticonvulsant medications, because we don't want the client going to seizure. Because usually if the client is placed on anticonvulsant medication, the client's seizure would most likely be controlled. In the event that the client experiences seizure, it is but important to maintain an oral airway. So in line with that, the client should be positioned on the side in order to prevent fallback of the tongue. Avoid restraining the extremities. Let the extremities move. You just have to support the extremities, because restraining the extremities can actually cause fracture. Avoid putting anything into the client's mouth, because that can actually lead to aspiration. Provide physical and emotional support, especially that the client had this post-ictal state. The client may be confused. The client may be embarrassed about as to what happened, for he or she is unaware of. So provide physical and emotional support. And more importantly, equally important, is to document the type of movement, the duration of seizure that the client had, because these are somewhat important in line with the progression of seizure, whether it is grand mal type or generalized, localized, or very specific. That actually ends our discussion of brain cancer. I hope you learned on this video. Stay tuned with the other videos prepared for you for oncology nursing. Thank you very much.